Wow, this is a great moment. I just want to thank everyone who's joining us at the Coffee and Chat in conjunction with MHM Health Consultancy. We are going to have a great conversation. It's all about man talk. And I know some women have written to me and go, but Michaeline, why are you doing this? You know why? Because women need to take an interest in men's health. You are mothers, you are sisters, your cousins, your aunts, your stepmom. I mean, come on about it. You are girlfriends, wives. Um, there is so much. Nieces. Come on, you have to take an interest in men's health. And today we have two of the most wonderful panelists here who's actually going to go into the clinical aspect of taking care of men's health. We are focusing on two aspects. We are focusing on prostate cancer, and we know most men, unlike women who can actually check themselves, is very difficult. So we'll go into that. And we also going to talk about, more importantly, we are also going to talk about erectile dysfunction, and it's a clinical issue. So there's nothing to be ashamed about. Grab yourself a cup of coffee, and whilst we get into actually having some discussion. So without any further ado, first thing I would like to do is to share the screen because I would like you to see what we're going to be talking about. In the meantime, Professor Rutimi, would you kindly tell us about yourself?
Good evening, and thank you for inviting me onto the Coffee and Chat show. It's a privilege to be here to talk. I am Rotimi Jayasimi, a consultant in obstetrics and gynecology, as well as the Associate Medical Director for Patient Safety at Basildon University Hospital. In addition to that, I am the Chief Executive of Trojan Medical Group, an infrastructure development group. As you know, as a gynecologist, my main area is women's health. But the difference is that I am a man, so I should also be interested in men's health. And that's why I'm here to support or to discuss this very, very important topic. And to Michaeline, thank you for having me.
Thank you. No, thank you so much for being here. And now if I could introduce you to Dr. Samuel Amenama, who is a consultant urologist and a sexopathologist. Dr. Samuel Amenama, can you please introduce yourself?
Yes, as you rightly said, my name is Dr. Samuel Amanama. I'm a consultant urologist and a sexopathologist. I'm a member of the European Association of Urology and locally to a member of the Ghana Association of Urological Surgeons. I have a sexual health foundation and I'm the Chief Executive Officer of the foundation and the director of a company. And in Ghana here, I'm a member of the Ghana Cancer Board. And at my region, I am the urologist consultant in the region there. So in brief, I think that's what I can say about myself.
Okay, thank you so much. My name is Michaeline Holdemarch, and I am the CEO of MHM Leadership Lab, MHM Health Consultancy, which is a core company, MHM Business Solutions, MHM Online Training, and MHM Virtual Office Assistance, which we just launched. That's our contact details. I'm a healthcare professional by background, but I've been running my own company for a long time. And also I sell ties, which is not applicable at the moment in this realm. So we're here to talk about this man talk. We're going to talk about prostate cancer, and we're going to talk about erectile dysfunction. And I would like to thank everyone who's viewing at this moment. So we are just going to go into some discussions. We are just going to go into having a discussion. And first to begin, I would like to ask Professor Rotimi, why did you have an interest in prostate cancer and this area of medicine? Because you are a gynecologist, you are an obstetrician, you are so well known in the global world of medicine and beyond. And sepsis is one of your, I mean, you are an expert on sepsis. So I know that prostate cancer and men's health is something that you're very keen to talk about. So can you just tell us, why did you have this interest in conjunction with your specialty?
Yes, thank you for that kind introduction. One thing I've done is not to box myself into any particular specialty, such as obstetrics and gynecology. And as a man, really, I should take care and notice of what can happen to men. And you may say, why prostate cancer? Now, prostate cancer is very common in Black people. It's even very common in men generally. And it is said that by the age of 80, about 80% of men will have prostate cancer. So the older one gets, one will eventually get cancer of the prostate. Now, the particular interest, why I've taken interest, is that genetically, it's commoner in Black people. The type of prostate cancer that occur in African ancestral people. So people in Africa, Black people in Africa, Afro-Caribbeans, Afro-Americans, when they do have the prostate cancer, they get it early, it's more severe, and it kills more of them.
Yeah.
And this disease can be prevented. So that's why I've taken an interest, so that I can help people, talk to my colleagues about it, as my men folks, about what they can do to minimize the risk of getting the cancer.
Okay, thank you so much. And Amina, can you tell us also, you are really, I would say, to do penile implants is such a difficult type of surgery, and it's a rare type of surgery. There's not a lot of people with your speciality. But what can you tell us about prostate cancer before we actually get into it? Why did you sort of even go into urology?
I would say, honestly, I went to urology not having so much knowledge about urology, so much interest about urology. It just came because our government wanted to sponsor some people for surgical discipline, and I was interested in surgery. So the only available discipline that was available was the urology. So I went into urology, and I found a lot of interest in urology. But my personal interest was or is in sexopathology, because here in Ghana, and I think in Africa, you have a lot of herbalists selling drugs for different purposes. And I could realize that whenever anybody is selling a drug, let's say for headache, they always connected it to the sexual function of men. Or this drug will help your headache and will help you to perform better. Or this drug is for diarrhea, and at the same time, it will help you to perform better. So my question was, what is it about men that always people are trying to play into it? And actually that sent me to search for orthodox ways. And I think when I went there, I really found it, and I'm happy. I'm in sexopathology and urology at the same time.
Okay, well, I'm glad that that you are in this in regards to to Black men. It's really comforting, I'm sure, for African and Afro-Caribbean men, who are all over the world looking from Texas. We've got people from all over the world who's going to be viewing this. It's great to know that we have someone who is Ghanaian and who's of African origin, who's actually have this speciality. So we salute you. So let's talk about the causes of prostate cancer. Is there anything that we can say specifically, Professor Rotimi? Is there anything we can say specifically in regards to prostate cancer? Because it is a killer. I mean,
Yes.
1 in 8, that's the raw stat here. 1 in 8 men will get prostate cancer. So is there anything that they have actually clinical findings about why?
Well, the commonest, at least from my understanding, and I'm sure Samuel will be able to put in his own view as well, is that the genetic aspect is a very common contribution to the development of cancer. And if there's a family history of cancer, there's the higher risk that a member of that family could also get cancer. And the surprising thing or interesting thing is that it's not only if a man or, say, a parent has had prostate cancer. There's also some association with breast cancer, ovarian cancer, and all of this underlie the fact that genetics also plays a part to it. There are other things such as lifestyle habits, the exercise you undertake, the types of food you undertake do contribute to the risk of prostate cancer. Obesity, for example, is also a risk factor. And that's where lifestyle changes, healthy living, eating certain, you'll be surprised, or you may be surprised to hear that things like broccoli, green tea, fish reduces the risk of having prostate cancer.
Wow.
So the risk mainly is genetic.
Okay. Do you mind, Dr. Amana? Could you tell us why? Can I say Dr. Samuel, or are you happy with my?
Yes, I'm okay. I'm okay with that.
Okay. So can you tell me, what is your findings? What is the common cause for prostate cancer?
Okay. We don't normally use the word the cause of prostate cancer, because whenever we use the word cause of prostate cancer, it brings the idea that when you do this, it will bring prostate cancer, or when you don't do this, it will not bring prostate cancer. So we like to use the word risk factor, your risk factor. Risk factor meaning that they have found that there are a certain group of people who will normally get it.
Wow.
So in prostate cancer, we talk of risk factors. Risk factors, I think Prof talked about it.
Yes.
Age, but the less
that makes sense. It does make sense.
Immediately, yes, immediately you cross 50, 60, 70, then you are getting to the prostate cancer zone. That is why in certain countries, like the Scandinavians, where life expectancy is very high, they have a lot of prostate cancer issues there. So age is always a risk factor for getting prostate cancer. Then the second thing is race. Race, being a Black by itself, put you at risk of getting prostate cancer.
Wow.
Where is, we have Caucasians there, we have Blacks there. And you find out that the Blacks have more of the prostate cancer than the whites or the Caucasians.
Wow.
So that one, we are not able to really find the exact reason why. You go to, let's say, America, the blacks are getting it and the whites are not getting it. Then the next one was, I think what Prof started with it, hereditary. If your parents have it, if one of your parents, no, your father had it, the chance of you having it is 2 times or double fold. If your father and your elder brother had it, it jumps about 5-fold chances of getting it. So these are all established risk factors. The lifestyle, I think Prof have already exhausted it, diet here and there, because they found out that like Japanese or the Asians, they age a lot. They age, but they don't get prostate cancer as other people get. But when the Chinese or the Japanese, they leave Japan and they go to America, for instance, and start eating like the Americans, change their lifestyle like the Americans, they get prostate cancer just like any other American will get. So the lifestyle, as Prof was talking, is very, very vital in prevention of prostate cancer.
So when we talk about age, yes, we talk about the over 50. So if there is a 40-year-old or a 35-year-old male, a black male,
right,
white male who would look at this video afterwards, they look at this and they in a comfy place and they decide to look at that. Do you think that they should also try and get screening because they probably have had their a grandparent or a parent who may have had prostate cancer in the past? Do you think that they should consider getting screening early, or should they wait until after 50?
As at now, if you have got a family history of prostate cancer, we want you to start the screening at age 45.
Mm-hmm.
At age 45. Normally, those lower than 45, like 35 we are mentioning, they can get symptomatic, but most of them will be as a result of just infection.
Okay.
Just infection, because prostate can get infected. And we will come to that. And the signs of infection is almost the same as the signs of cancer. So the lower age people are going to get an infection. The elderly ones are likely going to get the cancers.
Okay. I brought up on the screen for men who are going to be looking. The prostate is that little bubble you can see right there. That's what we're talking about. That just right here, just under your bladder. So let's go on then. I just want to, we talk about, and you don't talk about causes, you talk about the risk factors. But is there any preventative measures, Rotimi, that one can take? Professor Rotimi, is there anything that one could do preventively?
There's no prevention for prostate cancer. Like Samuel and I have said, I think lifestyle and exercise. You can see that in the screen you've shown. It shows a man who is undertaking exercise.
Yes.
So we don't know the direct link between exercise and the reduction of the risk of prostate cancer. But there's nothing one can do. Like we've said, the older you get, you will eventually have prostate cancer. My pathology friends tell us that by the time you're 80 or 90, when they do post-mortem in people who die of maybe a stroke or a heart attack, that's when they do the autopsy. They find that most of them have prostate cancer and they didn't know. And that's because it's been asymptomatic and maybe slow growing, especially in Caucasians. But you'll be mindful of the fact that in Africa lifespan is not as high as the Western world. So not
Yeah.
many Africans live to 90 or 80 or 90 before they succumb to some of the diseases. But before we go on, this is the chart. So I'm sure there will be some men out there saying, but what's this gland? What's this prostate? And what does it do? And I'm sure Samuel is better placed than I to tell people what the prostate gland is and why do we have it? What does it do? And where is it?
Okay. Dr. Samuel, would you like to pick up on that?
Okay. Well, when a man ejaculates during sexual intercourse, what comes out is called semen. And semen is made up of three main components. One is from the testes, which is the sperm, and the fluid comes from the prostate, and another fluid, which is the prostate, like energy, whatever the sperm needs to be viable. That is what the prostate does in its production, so that the sperm becomes what it's supposed to become to be able to fertilize an egg. So basically, that is what the prostate does in the body.
Okay. Okay, so thank you for that. Is it your also your clinical perspective that there's no real preventative measures that anyone can do in regards to getting prostate cancer?
Yes, you see, there have been a lot of studies. They have tried some chemotherapies. It looks as if it is promising. At one point in time, it just falls apart. But let me just add one thing to it. Recently, I think in one of these universities, I've forgotten, they found out that the more you ejaculate, the lesser the chances of you getting prostate cancer. Wow. And they said that if you're able to achieve 21 ejaculates in a month, it prevents your destiny of getting prostate cancer. And
I think some men are probably smiling from ear to ear now. They would use that as a sort of a reasoning behind prostate cancer prevention plan.
Exactly.
But let's move on to the visible signs or symptoms, because for women with breast cancer, it's so easy. It's not easy at all, but at least they have the self-examination that they can actually perform. Whilst for men, it's completely different. So it's not that it's easy, but at least there is an approach that they can use to self-assess and for early detection at sometimes, not all the time, but they can actually do their own breast examination very frequently. What about men? And that is for Professor Kimi.
Yes, there's no obvious symptoms that men get that raises the alarm or alert of maybe an impending prostate cancer. And that is why in a number of countries, as some has said, that from the age of 50, some people, it is advisable that you have your PSA done. That's the prostatic specific antigen blood test done. In the United Kingdom, it's 50. But we are beginning to see more people, younger people, and the age of having this screening test done is being lowered to 45, and even in some places, 40. So there's no symptoms. But for example, if you have blood in your urine, or you have urinary frequency, yes, you will go and see your doctor. And like Dr. Amanama has said, this could just be an inflammatory process. It may be an infection. So there's no specific symptoms that one gets. I think the key thing is the genetic history and the age as well. If you're over the age of 45, I would advise that you have the blood test done. Just like women have mammograms done from the age of 50, even though there's no symptom, that's the way we're going forward. And just to add that, the blood test itself is not diagnostic. You could have a high result and it could be due to inflammation, like Samuel has said, or you may even have a negative or low result, but be harboring cancer cells. So there are ongoing studies to see whether a screening mechanism or using MRI images of the prostate from a certain age might be able to pick up these cancers early.
Okay. Dr. Samuel, could you tell us, in your practice and in your experience, are there any specific symptoms? I know they talk about changes in the urine. So is there anything else that you would like to expand on that? Some people talk about pain in the hips and the back and the chest, difficulty in urinating, loss of bladder control, erectile dysfunction, and blood in the urine. What would you like to say?
Yes, we always say that there is no symptom, just like Prof said, which tells you that you have prostate cancer. And we say this, whenever you have any of these symptoms that you mentioned, it's a sign that the disease is already advanced.
Okay. Wow.
Immediately you begin to have any of these symptoms that you mentioned, that I'll mention again, it's already a sign that your prostate cancer is advanced. When you have frequent urination, daytime, nighttime, when you can't hold urine for long, when you have to strain, all these things tell us that you may be having a problem with your prostate.
Wow.
Not necessarily a cancer. It could be any of the three diseases of the prostate. It could be infection, it could be just enlargement, it could be cancer. So any of these symptoms tell us that you might be having a problem with your prostate. But to be very specific to know whether it is cancer or not, it's what Prof said. We have to do a PSA test. If we are not very sure of that, not that if you're not very sure of that, we do a PSA test, then we do what we call a digital rectal examination.
Yes.
We put our hand.
Yes. So can you hold that for a moment? Most men, complain about this anal rectal examination, and I think it puts them off. They find it very uncomfortable and very intrusive. Very, very much. They really don't like it. I remember sitting in clinics and men have to have it done, and you can tell they are really uncomfortable about it. So can you expand about that to give some of the men who haven't had that examination and may need to have one, what that entails, please, Dr. Amina?
Yes, simply, first of all, why is it necessary to do it? You can have a normal PSA value and still have cancer. Okay, you can have an abnormally high PSA value and you will not have cancer.
Wow.
But if I put my finger there, I can feel it. We know how cancers feel like. We know how the texture looks like. So my hand has to go there, feel it for myself, make my personal decision that no, irrespective of the fact that this person's PSA is low, by what I am feeling with my hand,
Mm-hmm.
there is something there worth examining. So though it's very uncomforting, but I think it's something that men must bear because that is the only means for now that helps the clinician to be sure of what he is dealing with.
What about imaging? Professor Rotimi talk about imaging, so the diagnostic aspect of it. Do you think that we are far advanced with technology, with health, all these great technology that is developing in the healthcare market, that we have reached the peak or the pinnacle of being able to address this with a less uncomfortable means of examination? Have you come
Yes, I
across
think
any?
I understand where you are coming from, but just picture this, that now every man that comes to the clinic just has to go and see the MRI radiologist before he comes to see the clinician. How the life is going to be,
Yeah.
the cost to the system and all. Meanwhile, when I put my hand inside, I can tell you there are certain cancers, you put your hand inside and you are almost 100% sure that
Wow.
you are dealing with cancer. So you don't even ask the person to go for an MRI. He goes for a biopsy, big they pick pieces of it and they confirm it or otherwise of it. So why do you have to make this is so expensive and so complex that I think it still has a place.
But Dr. Samuel, I have to say that you can say that because your experience, your wealth of experience, and I'm sure Professor Rotimi will agree with me that your wealth of experience and your confidence in your experience, it just comes out, it just echoes out that you can actually identify very quickly whether or not it is cancerous, and I'm sure you have a high percentage in that realism, and so we celebrate you in regards to that. But let's talk about the forms of treatment, because yes, PSA, everyone goes about it and it's quite high, and no, how soon do they have to come back for another PSA test because it's high but it's negative to cancer? So how long would you recommend for them to come back, Dr. Samuel, for a review?
No, if somebody has a high PSA and you go for a biopsy and it's negative, there are a lot of ways to go about it. One of the ways is that you repeat the biopsy after 6 months, because after 6 months, you have the chance of repeating the biopsy. Because biopsy is like, should I say, a lottery of a kind. Maybe the PSA can be at one point and you miss that particular point. So you may not be able to get it. So we are allowed to repeat it after 6 months. Apart from that, sometimes we think it could be, let's say, infection. Okay, so you give the person treatment for infection. There's a certain way the PSA will behave to tell you that it is infection. Like if the PSA was, let's say, 100, and you gave the person an antibiotic, and it dropped from 100 to, let's say, 20, you know that this is due to an infection that caused it. So you don't need to maybe worry yourself so much. But if it was 100, and after the drug or after antibiotic, it dropped to, let's say, 96, you know that no, there's still something there worth examining or worth finding.
Yeah.
Exactly, that's right.
Okay, so Professor Rotimi, there are many forms of treatment that is available for the men who are listening and their wives and all members of the family, unless it's absolutely very late when it was detected. But here in the UK, there are many forms of treatment. Can you sort of list some of those for us, please?
Yes, I think I'll talk a little bit from a gynecologist point of view. I mean, or perhaps from a lay person's point of view, and from what I've read. And perhaps before I talk about the treatment, is just to allay the fears of men about digital examination. I mean, in gynecology, women come for smear tests And yes, it's uncomfortable, but they'd still have to come for it. When I say have, they are advised to come for it to prevent getting cervical cancer. A digital examination in a man, yes, may be uncomfortable, but like Dr. Samuel knows, it probably takes less than a minute to do the internal examination. So it's just to reassure men that please don't be put off by having a rectal examination. I think it's just for your benefit. In terms of treatment, my understanding is that it depends. You discuss all types available. There are medical treatments that one can use. One of the drugs we even use in obstetrics, Zoladex or Prostate. And this one suppresses the male hormone, and in doing so may slow down the growth of the cancer. I remember a drug called Casodex, but I think Dr. Samuel will know exactly what it is. I remember because I'm aware of a colleague who used that for a while because
Wow.
he didn't want surgery. And I'm sure Dr. Samuel will tell us what Casodex is. Surgery, depending on what part of the world you are, if you don't have high-tech facilities, you have the radical prostatectomy, which can be extensive, it can be painful, and very bloody. Whereas if you have the technology, people do robotic surgery now,
Mhm.
and I think it's less. Maybe I don't know what word to say.
Less
Not
invasive.
being not being a urologist. I think I was going to say less traumatic, but I think I will let Dr. Samuel help me out on this.
Okay, Dr. Samuel, you got to take the baton on this. We're talking about prostate cancer, but what we really want to know, and for the men who are going to be listening and watching this, is okay. What are the treatments?
Okay, normally the treatment is dependent on at the stage at which you came. We have two stages, basically, organ confined. That means that the cancer is only in the confines of the prostate. It has not left the prostate. Then we have advanced one, meaning it has left the prostate. When it's only in the prostate, then what Prof said is one of the options, the radical prostatectomy. We go and remove the whole prostate. Surgical means, either robotic or our usual means. Then we have radiotherapy. Okay, radiotherapy, that's almost the same as the radical prostatectomy. The radiotherapy, you have the external beam where you go and lie down. And now there are very nice ways of doing it. We call something brachytherapy, where the radioactive substance is put inside the prostate.
Wow.
And you leave the hospital. So you'll be walking around like a walking, I don't know how to say, your body will be radiating radioactive substance, killing your prostate gradually.
Wow, that's a very mobile treatment.
Yes. And there are other ones in their infancy, cryotherapy, where they freeze the prostate tissues to death. We have the high intensity frequency ultrasound.
So there are many different treatments that people can.
Yes, that is where it is confined.
Yeah, so the men who are watching this and you're listening with your cup of tea or whatever brew you have, know that there are many treatments, and it's about having a conversation with your healthcare provider about what your doctor, your urologist, your specialist, about the best option for treatment. So I want to come back as a Black woman. I am concerned about, I was looking at the stats, I'm very concerned that Black men are more likely to be diagnosed in the late stages of prostate cancer. And I found that alarming, the stats for that. And, I am hoping that through this discussion today, that it will trigger some sort of get up and get seen, get up and get screening. If you have a GP or your doctor in Ghana, Nigeria, Texas, whatever, you need to go and say, I need to have a screening. I don't know my father's history. I don't know anybody's history, but I need to be screened. I need you to just check me and make sure that I'm okay, because late stages is a serious problem for the Black community. And Professor Rotimi, I would like you to sort of reach out to our brothers in regards to this. What would you like to say?
What I would say is prostate cancer, we talk about social determinants of health, where people talk about poverty, class, and stuff like that. It's been shown that prostate cancer has nothing to do with the environment in or the whether you're high class or middle class. It doesn't, and it's for that reason that people are now looking into research, really, the genetic basis for prostate cancer. And I'm aware that, most studies that are done in science are usually done on Caucasians, even the medication. But one of the recent developments is a Black American who is very rich, he's a billionaire, has given money for research into the genetic basis, how genetic modification, either you do a blood test or even just a saliva test, might tell you what your risk is. I don't know how far they've gone with the study, but that's going to be the way forward. What we have at the moment is what we've discussed: the PSA, the rectal examination, the biopsy, the imaging. But hopefully, in a few years' time, it might just be a saliva test or a blood test that will pick up this thing.
I totally agree with you. I think more clinical trials need to occur. I do believe that we need to bring in a bit more technology. I think the big pharmaceutical companies that just produce the drugs need to work so that it can be a much more individualized care pathway. And I think, the work that BAME Health Collaborative is doing, BHC is doing in regards to working with NICE as a stakeholder, looking at some of those clinical guidelines that's being pushed forward, how we can actually make it design it in a way, the journey pathway for our BME brothers across the whole journey, from actually screening, preventative treatment, and all of that. Dr. Samuel, is the same thing for you? Is it the same in Ghana, where there is, most of the time when it's picked up is quite the late stages? Because the stats what I was talking about was found in the US, the Caribbean, and also Europe. Is what do you say the same for you?
It's no different. 8 out of 10 patients who come to the clinic with prostate cancers are already advanced. 8 out of 10 who come are already advanced. And I can tell you, in my practice, I've practiced urology for about, let's say, I think 8-9 years. I've seen about 2 or 3 low stage cases. Only about 2 or 3 low stage cases.
Wow.
Almost everybody who comes is an advanced case. Period.
Wow.
And really, that is quite unfortunate. And that is why I think we should encourage our brethren to, and even our government. I mean, if we talk of Africa, is the PSA screening test available for most men? Do you have to dip into your pocket to have it done? that much I don't know. I don't know how much it costs to have it done in Africa. But this may be, and I'm happy you brought up this topic tonight, so that people can be aware of it. I think it's more of the awareness that these things do exist, and that men, especially men from the African ancestral origin, are at risk of it. And hopefully, maybe from the age of 40, 5, I would advise people to have their PSA test done. And if it's high, one of the things one can do is to have it monitored, see whether it's rising, whether it's gone. One single test doesn't tell us that, yes, this is cancer. You may need a number of tests to see whether it's rising or it's gone back to normal, because it may have just been an ordinary inflammation. Even riding a bicycle can raise your PSA level. So before you go for the test, you're told not to undertake no sexual activity, no riding of bicycles or even horses, because that is where the prostate gland is. So I think it's great. And like I said, I'm happy you've brought us in to talk about it, to raise awareness. Like Dr. Samuel said, 8 out of 10 people, by the time they present, it's advanced. And once it's advanced, the cure rate, the survival rate is low.
The reason I decided to sort of explore this, it's because when I looked at the stats and realized that Black men are more than likely to be diagnosed in the very late stages, I was really concerned. And that is coming to our next question. What should women be doing to support mental health journey? From my perspective, it's about encouraging your sons, your grandfather, your uncles, your neighbor, your friends, your partner, the men who are in your network, to actually say to them that you are over 40 now, and you should make sure that you have screening for prostate cancer, because it is real, and you may be walking around with prostate cancer and don't even know you have it. That's the scary part of it. You could be walking around with it, continuing your life, and you don't know. Your sexual activity is not diminished. You are just a normal life, and then one day you realize you find out that you have prostate cancer. Dr. Emmanuel, what do you want to say that women should be saying to their male the male members of their family, friends, network, social, churches, the mosque, all of that? What should they be saying, and any other religious bodies?
The prof.
Dr. Samuel.
I think it's to you.
Okay. Well, first of all, from the urological point of view, we want people to know about it first, have a knowledge about what prostate cancer is, the pros and cons of investigations, understand all these things, then you go in for screening. For reasons that I cannot go into, like we are not advocating like, oh, the whole of, let's say, Accra, everybody come and screen for your prostate cancer. We don't advocate for that. For now, we are advocating, your father had it. You must, as a son, you must, as a brother, you must, as a close relative, you must do it. Without that history, anybody who wants to have it done must have listened to something like this, understand the pros and cons, what is going on, then decides that based on these factors, I think I have to go for it. Yes. This is what I think.
The risk factors, as you said, yes.
Right. That's right. Mm-hmm.
Okay, so we are gonna tidy up this now. I just want to thank you, both of you, for this great discussion about prostate cancer. And is there anything else that you would like to add, Dr. Samuel, in regards to prostate cancer?
I'm saying that prostate cancer is a killer. And sometimes when you see patients who come in advanced stages, and you just have to try and manage it till the day they exit, sometimes it can become very sad. Meanwhile, if they had come earlier, they could have been helped. So I'm advocating that get a lot of knowledge about it. If you fall within the bracket of people that need to be screened, go and screen immediately. It's always earlier than later.
Thank you so much for that. Professor Rotimi, is there anything you would like to say in regards to closing statements in regard to prostate cancer?
Yeah, I would just re-echo what Dr. Samuel has said. And just like for most health conditions, I think both men as well as women we should look at our lifestyle issues. Exercise, balanced, normal diet will help a lot of us. And there's a song that goes like, let's talk about it. Let's talk about it. I think
yes.
We should continue this conversation using various platforms to tell men to step forward and have themselves checked.
Okay, I'd like to thank everyone. We are just going to take a few minutes and for both panelists to get themselves a nice cup of tea or refresh top of their cups. And we are going to come back and talk about sex pathology and what that is. We're going to talk about erectile dysfunction. We're going to talk about penile implants, and we are going to talk about how you can contact both these medical experts and to be able to follow up in regards to what you've heard today. So grab yourself a quick cup, and we are going to be back in less than 3 minutes. We're just going to grab ourselves a cup. Thank you.
Thank you.
So if you can grab yourself a cup, that would be great. Do you have all that you need, or you want us to continue?
Well, I've got my cup of coffee here.
Okay. Cheers. What about you, Dr. Samuel? Do you have your cup?
Yes, it is there.
Okay, great. Well, I thought you may need a break, but seeing that you don't, we are going to go straight into that. What is pathology? Can you tell us what that is? Because people have been writing to me and going, what is that? So can you tell us what that is?
Well, sexopathology has got to do with, it's a surgical discipline which tries to address issue of sexual dysfunctions in men. Mm-hmm. Sexual dysfunction, we have it in men and we have it in women. For now, the gynecologists are still holding on to that of the women, and we are not going to take it away from them. So we, the sexopathologists, are taking that of the men. Basically, we have to deal with libido in men. We have to deal with ejaculation disorders in men. We have to deal with erectile dysfunction in men and issues about orgasm. Mm-hmm. From the medical treatment point of view and the surgical treatment point of view, that is what sexopathology is all about. But I think very soon we are going to take that of the women also from the gynecologists. if Prof will allow it.
Certainly he will. Certainly he
We're
will.
going to have a tough one there.
Yes, we will. So you had said that that this is really exploring, a discussion that people are always very shy to discuss. And a few women had contacted me and said, "Oh, Michaeline, you're so brave to talk about that." And they got to understand that we live in a modern world, and this is a clinical concern. This is not something that is titillating. This is clinical, and therefore it's about supporting your loved one through the process. And if you don't know, then you would miss the mark. And for the man, it is his self-confidence, his whole imagery. It's about his performance as what he thinks is very important to his manhood. So therefore, I want to ask you that, this area of clinical medicine is normally so quietly discussed, is so quiet due to the taboo. What is that like in Ghana? Because, I have my office in Ghana. I am so happy I opened my office in Ghana. I have wonderful staff, Rebecca and Harriet, and I've got Henry who helps, and Ruth and all of that. And the Ghana community, I just trying to understand. So would you be able to sort of, tell me how do they embrace this concept?
It's the same everywhere. It's the same everywhere. When it comes to like erectile dysfunction, for instance, every other man has it between the age of 40 and 70. Every other man. But I don't know of any disease that every other person has it. But erectile dysfunction, every other 50% of men between the age of 40 and 70 has it. But I can tell you, only about 10% of them come to the clinic. Studies are only about 10%. 90% of men would rather stay in the house, listen to the radio to know the latest Japanese drug or Chinese drug, and just be buying it and just be consuming it.
Mm-hmm.
It's shrouded in secrecy. And the worst of it is that even at the clinic, somebody can come to the clinic who maybe for, let's say, 5 years, he was not able to have sexual relationship or sex, and you're able to treat, and the person even will not tell his closest friend that you can get a help from this person, because he feels that if he tells the person will know that he had that problem. I've had a patient who, when he came to know that somebody had got a wind that he had been treated, actually had a penile implant. The person said that he was going to commit suicide because somebody had heard. Meanwhile, he's now okay. He's able to have children with the penile implant, etc., and etc. That's how men, I don't know, we are so secretive and distant about this issue.
And you see,
I can explain.
What it is about, the less than concept, isn't it? The psyche. Professor Rotimi, you like to come in here? It's a less than psyche, and who else know and don't want anybody to know. So, Professor Rotimi, what would you like to say?
I don't think it's just an African thing. I think just with most diseases, if you look at urinary incontinence in men or women, the older women get, they do have incontinence. Yeah, many years ago, people did not talk about it. But with education, people are now talking about it and seeking help. It's the same with erectile dysfunction. And if you go into motorways in the United Kingdom, some of these adverts are placed where the urinal bowls are saying there's treatment for it. Don't feel shy about it. Talk about it. And I think that's one of the messages we've also got to tell our African brethren or Afro-American brethren, Caribbean brethren, that there's nothing, you shouldn't be ashamed of it. I think as doctors, we swear to confidentiality. And when you go and see a doctor, it's not as if the whole city is going to hear about it. So I will encourage people that you're not alone. And there is treatment, or there are treatments for it. And I'm just going to maybe sound some caution here. Like Dr. Samuel has said, there are a lot of online medication, concoction, lotions, and all sorts of things. People have got to be very careful about it, because you don't know whether they carry toxins that may be damaging other organs, such as perhaps the kidney. I think, I don't know what Dr. Samuel's view is about all these online, even local herbs, and you hear all sorts of stories. But I think some of them may contain impurities. So people have got to be very...
You know that type of medicine, I don't say much about it, but my concern, and when I did the breast cancer with Dr. Beatrice Wifey, I was concerned that instead of going to your medical practitioner, you would first go and seek guidance from these local, i.e., non-clinical doctors. And by the time you've gone through their treatment, it is so late in the day, both for for any form of cancer, or even for increasing your opportunity to have children if you are infertile due to erectile dysfunction. So it's really important for you, if you want to use the two systems, that's fine, but make sure that you get that clinical intervention very early in the day. Dr. Samuel Aminola, what do you want to say about that?
Yeah, you see, I think most of this thing is actually lack of knowledge. First of all, lack of knowledge of the fact that there is help outside there. Medicine doesn't like talking about 100%. Medicine is always conservative, trying to be very, very conservative in this thing. But sexopathology is one of the disciplines that is able to say that every man, irrespective of your condition, sexually can be treated. Every person can be treated. So far as you have something in between your legs, it can be resurrected. And people don't know about this. And secondly, erectile dysfunction, for instance, I always say that can be a blessing. If you have erectile dysfunction, it can be a blessing.
Wow.
Because, yeah, for instance, if you have high level of cholesterol, okay, cholesterol will block your blood vessels.
Yeah.
If it's blocking the blood vessel in the brain, it can give you stroke. If it blocks the blood vessel in your heart, it can give you a myocardial infarction. If it blocks the blood vessel in your penis, it gives you erectile dysfunction. Okay. So now, if it's blocking your brain, you may not see it because you are walking around, that's what's happening. If it starts blocking your heart, you may not see it. But immediately it blocks your penis, you will realize it.
Yes, that's a powerful and a description.
So
that's powerful.
Go to the doctor, and the doctor, and you go to find out that you have high levels, and this high cholesterol level is causing problems all throughout your body. Let us stop it now.
Wow.
So if not for the erectile dysfunction, you would not have gone to the hospital. And your brain one day will go off. Your heart one day might go off. So erectile dysfunction in the hand of the professional can be a real blessing.
Wow.
But if you sit down there, just take some drug, The easiest part is getting erection, but the most difficult part is solving the underlying problem. And that is what professionals do. We want to go and solve the underlying problem so that later on in life, you don't get some unexpected diseases which started long ago.
Okay, so
There's
Dr.
one thing.
It is suggested that erectile dysfunction is related to obesity, diabetes, stress, mental health, and well-being, just to name a few. Could you give, go into the associations with other comorbidities and other illnesses?
Yes. Um, if I want to mention the diseases which can cause erectile dysfunction,
Yes.
that will be another 3 hours to talk
Okay.
about it.
Just give us
But
your top five. Your top five. We welcome your top five.
yeah, but let me just say this. Erection is for you to get an erection, you need a good nerve, a good blood vessel to carry the blood, and a good hormone we call testosterone. Any disease that affects your nerve will eventually affect your erection, like stroke, spinal injuries, your nerve, it will affect your erection. Any disease that will affect your blood vessels, hypertension, name it, high cholesterol levels, will affect your erection. Then hormone, testosterone, Casodex, like the drug that professor was talking about, will affect your hormone. But let me bring it clinically. Clinically, there are 3 main diseases. In fact, if you go to any hospital with erectile dysfunction, these 3 things must be looked at: hypertension, diabetes, and the cholesterol level. These are
Wow.
the basic in the clinical setting that must be tested before we go further.
This is such an important topic. It is such an important topic because it gives clarity to people who probably suffering for this from, for a long time. They're quite ashamed of it. There's nothing to be ashamed of. This is a clinical situation, and therefore you are given that, you're letting them know it could be an underlying cause why this is happening. And, Professor Rotimi, before I come to you, Dr. Samuel, is there a link between erectile dysfunction and infertility?
Oh, yes, there is. There is.
Okay.
Infertility has got to do with the quality, or fertility has got to do with the quality of your sperm or your semen, the quality of it. And no matter how quality the sperm is, you need to carry it to the cervix of the woman for it to continue for fertilization.
Yeah.
And for you to carry the cervix, if you are going the natural way, it's only by good erection, libido, etc., etc. So if you don't have all those things, you don't have the means to carry it to where it's supposed to be.
Professor Rotimi, as an obstetrician and a well-known gynecologist, I mean, do you ever sort of, because we're talking about men here, but women also suffer from sexual disorders as well, and they go on off it completely due to hormones and all of that. Do you ever sort of refer people? How often do you get to refer people to a pathologist, a sexopathologist?
You're talking about female patients?
Yeah. Do they talk about it? If we do on an average of 10 patients, do people talk about, that they are really not, interested, or do they ever raise that sort of thing with you as a gynecologist?
Yes, they do. In different ways, not just in an infertility clinic. At times they present with painful intercourse, or inability to have sex at all due to pain. And it is very important that one takes a good history, take time to listen and to question. because in doing so, you may find out what the underlying cause is. For women, it could be pain. I mean, I could tell you this, that I've seen a woman in a fertility clinic who said she couldn't get pregnant. And this was many years ago. And when I examined her, she was still a virgin.
Oh,
And oh yes, and I said, "Oh, what's been going on?" And she said, "Oh, it was pain. It was painful. I've got an understanding husband, so he doesn't push hard. And all I had to do was talk to them and say, look, just go back home, and tonight is the night. I'm sure you know that song." And they were successful. But
okay.
but it can be as bad as women having to have a surgical removal of the hymen. It
Mm,
does happen. And I think one of the other things I'm going to talk about, it's about men. Men just want to get in there without any, you
preparation.
know, preparation, yes. And in doing that, it can be painful.
Mm,
So I think what I would say is, yes, there could be underlying medical issues, but also there could be psychological issues. And you wouldn't be able to decipher which is which unless you take a good history, and then you might require, the patient or couple might require counseling. I do tell people that all you have to do, especially if I'm talking to the ladies, look, your man is stressed, just come back from work. Before he arrives, put on Barry White, petals, candlelight, soft music, relax, and yeah, because what it's called the vaginismus, when the woman is all tightened up.
yes.
But I just think some relaxation exercise is important.
Yeah, and I think, in this COVID period, people have so many stresses. They have unemployment issues, they have economic, they have social issues, and all of that can. I mean, Dr. Samuel, you would be the one to really comment on this, but one would think in this COVID period where so many people have been out of work, um, erectile dysfunction, could be, linked to all these psychological social issues that people are facing at the moment. So having that nice Barry White environment is not top of the charts, especially if you're thinking about the fact that you're not economically in a comfortable place. What advice do you have?
When this COVID came, one thing that I said is that we are going to have a lot of influx of patients after COVID because men, one way they used to solve the erectile issues is that, oh, I'm busy at work, and they stay at work late into the night, come to the night, I'm tired, and sleep. Now, because of COVID, you can't go to work, you are in the house, you can't say, I'm tired, you have to perform. So
That's a good way of looking at it.
So COVID is exposing, is bringing the reality of the issues at hand. And I always say that there's help outside there. There's help outside there. Medicine has gone very, very far. Orthodox medicine, has gone very, very far. And there is there are answers outside there. Seek it, and you always get it.
Okay, so we've talked about that. Just gonna ask Professor Rotimi one quick question. Rotimi, women they've been saying to me that childbirth is one of the causes of theirs, the sexual concerns. What do you have to say about that?
I think what happened, I think I know where that question is coming from. Usually when you have a baby, before you have a baby, it's the husband and wife married. You have time for each other. The woman devotes her time to her husband or partner. But when the baby comes, the mother has to look after the baby, breastfeeding, toileting, And at times, men feel ignored or left out of the situation. And it can create tension between couples. And it can even lead to sexual issues, sexual dysfunction issues. And that's why it's good to talk as a couple, attend antenatal classes so that you know what to expect.
Prenatal classes are really important, isn't it?
That is correct. So, and again, talk about it, get help. And if you talk to your spouse about it, I think these are things that can be solved. There are things that can be solved. The only other issue is when you don't have a good housing facility. Maybe you have just 1 bedroom or 2 bedrooms, and you've got 3 children in the house who can just barge into your room anyhow. It does affect relationships, but I think so. That's what I'll say. Yes, pregnancy, if not handled properly, because mother is breastfeeding, she's tired, it can affect sexual relationships.
Yeah, and if that is happening, they can go for treatment, and
They
they can go for therapy. And there are lots of places here where they can go for therapy, and there are various organizations. I'm not gonna name them, but they're also available on Google in regards to that. So we are going to come to you, Dr. Samuel, because I have had so many emails, messenger from my Facebook messages about surgical treatment, implants.
Okay.
Implants. And what I did, I took your success story by doing this implant, penile implant, and the gentleman was able to be able to have a baby. They had a baby. That's a success story. I mean, that is just fantastic. And I don't know how to tell you, fantastic. And the surgical process itself, getting a man psychologically in the right place that he's going to have this surgery is the first thing, because he's wondering, is it going to get worse? Is it going to get worse? But you are such an expert in this. Could you just, because the my messenger, Facebook messenger was, there are 3 things. So I'm going to come to those 3 things. But the very first thing is, how long is this surgery?
How long?
Yes.
In terms of
time. In time. Is it 30 minutes, an hour surgery, 2 hours? How long does it take for you to do this surgery?
Okay. On a normal day, 1.5 hours should do. An abnormal
We can't hear you.
day, 2.5 hours, 2 hours.
Okay, so could you tell us a little?
Averagely 2 hours.
Okay, good. So could you tell us a little bit about the surgical procedure and making that determination, please?
Okay, first of all, just like any aspect of medicine, surgery is always the last option. We don't give surgery to people. You come, you have erectile dysfunction, then we are going to operate you. No. We always want to try other options. Medically, give you some oral medication, injectables, other things. When all these things fail, then we resort to surgery. Although in certain countries, some people want to say that I don't want any medication, I don't want to take any drug, I just want to go for surgery. But we don't advocate that. We always want to try all other options before we go for surgery. Although the surgical treatment is more definitive, it's the final treatment. When all other things fail, that one is not supposed to fail. It will almost always work. And it solves the problem forever. Forever in the sense that maybe for the next 20 years,
Great. I just need to step back a little bit. Do you offer some sort of counseling? Because that's one of the questions. Is there some sort of counseling that people get beforehand during the time? Because obviously they can be trying lots of treatments, and you've got to get their partner involved, their wife involved, and they would need to get their wife involved, and to be painstakingly, trying love potions to this, sweetables, to all sorts, and it's that involvement in that, because it would affect her. Dr. Beatrice is here, and she's saying that it would affect her. How long is this going to go on? Their sweetheart. How long are you going to come back and bring these? When we know you could have surgery and this will be fixed. 2 hours you lie down there and it'll be fixed. I mean, we need to really.
You are right, but I can tell you honestly, I think 9 out of 10 patients wouldn't want even their wife to know that they are going for that surgery. I'm telling you, I had only one patient who came to the hospital with the wife. Only one patient. The other patient, who was just close, had the surgery. The next day, when he saw that everything was fine, before he rang the wife and told the wife that I've been admitted at the hospital, please come and see me. So men will not even want their wives to know when they are going for this surgery, although we try to entreat them to do so. But we give them a lot of counseling. We give them a lot of counseling.
That is important, the mental well-being of that individual, and I suppose it will also be part of their whole thinking. One of the things that I just want to go back again about, erectile dysfunction. Is there an age range in regards to this? What about the 23-year-old? Because we know the ones who take drugs, recreational drugs, it can have an effect on your erectile performance. So is there an age range where you would say, no, I wouldn't do erectile implants for you? Is there age range? And if, nowadays, a nice 80-year-old man who might be very fit, and decide, he would like to consider erectile implants. I mean, is there an age range in regards to this? Because you do have a question from a 78-year-old who is anonymous. He contacted me on Messenger, and he said that he is fit. He's never been hospitalized, and he's very keen to know about whether there is a place for him to stay. He's interested in the implants. I'm going to exchange his details with you. I told him that. And he wants to know average costs. But more importantly, he has never had any issues medically, but he needs an implant because he has a beautiful 25-year-old girlfriend.
Okay, first of all, I would say that Abraham was 100 years.
He's going biblical now.
So honestly, medically, we don't have any age range or any cutoff point. You must be fit. We say you must be fit for sex.
Yes.
You can find an 80-year-old man who can jog around, walk around, and you can find a 23-year-old boy who walks about 100 meters and is breathless.
Yes.
Okay. So we assess your health. Are you fit for day-to-day activity? Because no, sex is work. Sex is a lot of work for men.
Yes.
Bob can tell you, it's a lot of work for men. So
hold a second. It's a lot of work for women too. If you beg,
okay.
I'm sorry. I wouldn't have that. It's a lot of work for women as well. But however, holding that for a moment, we know for a fact, just a second, Professor Rutimi, we know for a fact there's enough clinical cases whereby men have actually passed whilst doing their performance. Yeah. So we recognize the extra energy levels. However, it has worked for both parties. I'm sorry. Yes, Professor.
Okay.
I think I'm hearing strange things. I thought it was for pleasure. That's now you're saying it's for work, or it's what, I don't know. I thought it was for pleasure. I don't know. So I think what I would say about the 80-year-old man and the 26-year-old
25-year-old. 25-year-old.
25-year-old. I think that man is looking for trouble. A 75-year-old man going for a 25-year-old young girl. You're looking for trouble. Your heart condition is probably not as sweet. So
maybe it's like a Duracell battery. Maybe. And Dr. Samuel did say that you may have a 21-year-old who cannot do 8 steps, and you may have this gent who said that he can really go the mile and more. So coming back, Dr. Samuel, now that we've had a bit of a breakthrough in regards to this, can you share and tell us about the medical tourism aspect of it? Because, I spoke to Dr. Beatrice and yourself, and the reason why MHM Health Consultancy is driving this through the coffee chat is because I do believe in globalism in regards to medical care amongst our people across Africa, across the Americas, across the Caribbean, and all other geographical areas. We are really experts in so many different areas. And, sometimes there is a little bit of comfort, cultural sensitivity that can be applied to these type of topics. And hence I decided to do this today. And I gave it a lot of thought in regards to this. But one of the things I want to come back to you, because, you are, a sextopathologist. And one of the things I want to ask you on a real clinical level here, are there any diagnostic tests, any laboratory results that you sort of put that patient through before making any sort of diagnosis?
Oh, when it comes to erectile dysfunction, basically most of the diagnosis is brought by the patient. Okay. I cannot perform. So what he says is what we are dealing mostly with. And there are certain questions that helps us to know whether it is purely psychological, because somebody can not perform because of some psychological issues. He has some stresses of life. And there are certain things that will help us to know that. But there are some certain people that we know for a fact. For instance, somebody with diabetes, after 5 years of diabetes, will start experiencing erectile dysfunction, either a mild form or a moderate form. So a patient comes to me, 10 years diabetes, I cannot perform, I have hypertension. I know that with these 2 factors, definitely it is obvious that you cannot perform. Although there are certain investigation tools that we have, we want to see the blood flow in the male organ, whether the blood flow is adequate or not. But we don't rely so much on that. We rely so much on what the patient is telling us. We can give him some drug, he goes and it's not working. With all these factors, we know that what the patient is telling us can be trusted. Back to the age. Yeah. Back to the age. You can have a patient who is 20 years old, okay, and has got a condition we call priapism. Priapism means that the penis one day got erect and stayed erect over a long time. When they have that condition where the penis gets erect and stays on for a long time, after some time, when the penis gets flaccid or the penis bitumensis, medically we say, the penis is no more a penis again. It will stop working. You have erectile dysfunction. So though he's 23 years old, that person might need an implant.
Yeah.
The youngest implant I've done is the age of 35.
Wow.
The person was 35 and he had the erectile dysfunction at the age of 24. When he was 24, then he had erectile dysfunction. And for 9 years, he could never, though he was married, he could never had sex.
Wow.
But he didn't know that penile implant was an option. Till later, he heard that it was an option. We got it fixed. And now he's living his life. He's got a child, etc. and etc. So age is not really a matter of this thing here. Young as you are, if the condition demands it, we do it for them. But it's not always the first option. It's always the last option.
So that is interesting to know that there are other options that people can take, and Viagra has been on the market for a long time, and there was the Viagra craze until people could not come down from Viagra, couldn't go to work because they are taking too much Viagra. Is that part of the treatment plan?
In fact, I don't want to. Sometimes we are a little bit.
So let's not
talk about specifics.
Yeah.
Because
so for legal aspect, we're not going to talk about Viagra, but we're going to talk about drugs that have a stimulating effect that can last for a long period. Yeah. Some people they have places they could go online. I'm not going to call any companies. They're going to go online and they're going to order something that's going to give them that long lasting effect. But what kind of damage does these products that they can order online, all these testosterone products and spray on and sweets and all sorts, what is the effect of those on their having really good medical treatment?
You see, just recently, there was a study which showed that people who watch pornography tend to have erectile dysfunction because when they watch the pornography, they sensitize the body to some level that their wives or their spouses are not able to get them to that level that they are used to when they are watching pornography. So when they go to real life, they tend to have erectile dysfunction. The same vein happens to you when you are taking all these drugs. You are not sick, you just want to overperform or over-impress, and you take these drugs. When the real time comes that we have to give you these drugs, they do not work again.
Okay.
And sometimes when what people read on the internet may not be the absolute truth. Wanting to have sex for 45 minutes, for 1 hour. 1 hour, what are you doing? 45, what are you doing? It's not practical. These are all photographic something that they are showing, and people want to go in for that. And before they realize things are not going well for them sexually. So I don't really agree with people when they go buying all these drugs to overly perform.
Okay, so we're just going to recap on that before we sort of give you details and all of that. I'd just like to say thank you both so much. So in regards to erectile dysfunction, we know now that, it could be underlying diseases that you may have. It could be because you are engaging in activities like pornography. There's enough statistical evidence to support that. We know it's psychological issues. We know it's obesity. We know it's quite a few things. But Dr. Samuel, I just want to ask you, do you offer international services? Do you have people, because that's a question that was sent and I added to the list. Do you, because I've got two people from a particular state. I'm not going to call that state because they are both from the same state in the USA, and I don't want it to be said on my coffee chat that is well known for this. So I shall not say the state, but do you offer international services?
Oh yes. Now even we are just waiting for the COVID this thing to be over, for the borders to be open to get patients who are ready to come from outside. I mean, international patients. We offer that service. You come, you have somebody meet you at the airport, get you to the hospital, get it done. Normally by 9-10 days, everything should be over for you to fly back wherever you are. And we give state-of-the-art service. We are experiencing whatever we do, and we give you very good services in this regard.
So I understand that you do a collection from the airport. You collect them from the airport. You take them to a place where they can actually stay comfortably, where they have all the amenities that they need, and
yes.
And to discuss fees. Your email is, I just put it up on the screen, but would you call out your email again, please?
Okay, it's W for world, O as in office, I as in Isaac, S A M as in man, A at yahoo.com. WOISAMA at yahoo.com.
So thank you so much. So all the people who have contacted me on Messenger, Dr. Samuel will gladly take your questions, and he offers international service. And some of you ask how long it is, it's 2 hours, but there's no guarantee that he will automatically do an erectile implant for you. He will discuss, and just like any other clinical case, there will be a clinical assessment to determine whether you are fit for that procedure. So it's really important for you to have that conversation, and he will discuss with you. And the flights, there are many flights. There is the KLM, there's the BA, there's many flights that you can actually take. And Ghana Airport is very sophisticated. He is based in Kumasi, but he will be able to arrange so that you will be seen. I must say, Ghana has fantastic hotels, and I love Ghana. That's why I'm promoting, because I've got my office, MHM Health Consultancy. We in Jawalu, and that's where the clinic that I'm going to open is going to be there as well. I'm super excited, and I love Ghana. I wish I was there for some good shito and yam, and and to have some good pong yam and everything, some fresh coconut water and plantains and everything. So thank you so much. It's such a privilege to interview someone like you and to talk about the men's health in this context, which is core to their imagery, and it's very important. Professor Rotimi, you are someone who is well known for your humility, and the years now you are like a brother, and I've seen you extended yourself beyond. As an associate medical director, you push patient safety to the brink, and consultant in obstetric gynecology. You also well known as a fellow of the West African College of Surgeons. You so much to your belt, including being a health and safety, women's health, and sepsis expert. In regards to your offering for people who are looking, especially people from all over, and let's talk about the women from Saudi Arabia that we were talking about, and Muslim women. I know you said that in regards to that you will get you'll arrange the appropriate people to be there, but you're quite happy to do remote conversations. Could you expand upon that, please?
Yes. Prior to COVID, we did undertake telemedicine, teleconsultation, prior to people traveling down for definitive treatment. COVID has shown us how much more we can do by taking consultation.
And yeah.
If people have reputable laboratories in their countries of residence, they can undertake their investigations before coming for definitive treatment. That's in obstetrics and gynecology. In addition to that is the consultancy role for instituting clinical governance framework for institutions. You alluded to the patient safety aspect of the work I do. And that's another area that I am open to. And I've helped a number of institutions set up systems to protect our patients. I've learned a lot from Dr. Samuel. I believe that when his patients succeed, I'm going to be seeing more babies. So thank you, Dr. Samuel.
Yeah.
You're giving her work to do in the maternity department. So it's been, I've learned a lot from what he spoke about tonight. I didn't know what sexual pathology was. I had to go and read about it or Google it.
Yeah.
But tonight, he's thrown a lot of light into it. And so I've had a good evening. Thank you.
Okay, and just before we close off, Dr. Beatrice is saying that she was very impressed with the first penile implant, which she assisted at the Peace and Love Hospital. I can't wait to go to that hospital and have a walk around in Kumasi. And she said she thinks women also see how some of the men do pant for breath during and after intimacy. She agreed it works. It works really well. That just goes to show that penile implants, you are going to be bombarded. And if you do need someone to collect the money for you, I am a very good financier. Just keep me in mind. I could be the middleman for that. But coming back on a serious note, Dr. Samuel, it is an awesome area of practice that you've targeted, and because it's an unspoken subject area, most of the men are shy to come on this broadcast. They are sending me messengers, and I think it's because they think their identity will be shown and they don't want to be seen. They rather look at it on video, and that's perfectly fine. But it's really important. Let's just capture this to recap on everything. We start with Professor Rotimi. Most people know who he is, and if you want to get in contact with him, the email is there. You can look up his email and he will be able to offer you private service. Dr. Samuel, thank you so much for joining us today. And just to recap, you do collections from the airport and you take them back to the airport. It's a 2-hour surgery. They can email you for the costs, for the approximate cost, where you can send them the flyer, and you do offer medical tourism. And Ghana is a most beautiful place for them to visit. So with that, I'd like to say thank you all for joining. With you, Professor Rotimi and Dr. Samuel, last words, please. Last word, Professor Rotimi, before we end this broadcast.
My last word to both men and women is know your body, be aware of your health. And if you see any departure from normality, please present to your doctor early. Prevention is better than cure. Early presentation also gives you a better outcome. And I will also say, watch what you do in terms of lifestyle changes, smoking, alcoholism. Keep your weight and keep fit, and stay safe in this era of the COVID-19. Stay safe, and wear a mask.
Okay. Dr. Samuel, your last few words before we end the broadcast.
Yes. Maybe I will just start by one misconception about penile implant. People think that after the surgery, you have some tubes somewhere, you have some remote control, you press it, and in fact, this is a surgery that if you don't even tell your wife, I'm not saying don't tell your wife, even if you don't tell your wife about the surgery, your wife will never know that you have an implant.
Wow.
The only thing that your wife can say is that my husband once was blind, but now he can see. So,
but sorry, I need to ask you a very fundamental thing, because that came through on my messenger just now. What about the pain, Treasurer? Is there lots of swelling and pain?
Pain.
Yes.
Oh, like any other surgery, based on the pain, we give very good pain relief for the period of time that normally by the second day, the patients are up and walking around with very little pain relief. So there's not much pain that people should be afraid of. So there's no. Maybe my last words is that medicine has gone very, very far. Research is ongoing. People are breaking new frontiers. And it's all for our benefit. Don't stay at home till it gets worse. See your medical practitioner. Maybe the thing that you have been struggling with all this your life is just some meters away from you. Go and you always get help from the medical practitioners. Thank you.
Thank you. So I will just go back to recap. I'd like to thank all the viewers. This is my company. I am Michaeline Holder-March. This is how you can contact me. I've got an office in Ghana, in the region in Ghana, and also in the UK. And on behalf of MHM Health Consultancy and Coffee Chat Now, I'd like to thank everyone for joining us at a Man Talk about prostate cancer and erectile dysfunction. It's been so informative. I expect you women now will actually talk to your sons and uncles and father, grandfather, boyfriend, friends, ex, nephews, everyone in your network. Remember that 1 in 8 men will get prostate cancer. And, we talk about the PSA blood in regards to that. I want to thank so much Dr. Samuel Anamana, consultant urologist and sexual pathologist, for the time he's taken to actually speak to us about this matter. We also would like to thank Professor Rotimi Jayasimi for his work here in regards to concerns about women and their own sexual dysfunction, and also the concerns that they have, and it's also treatable, and his insight about prostate cancer. That is Michaeline. This is me, Michaeline Holder-March. You can find me on LinkedIn. You can find me on Facebook. And those are some of the companies that I've worked for. Remember, the prostate is that little gland there. And the best way is for a doctor. Don't be shy if a doctor wants to do that examination. It is important. And with that, we like to say thank you so much and have a great and wonderful evening. Thank you.
Thank you.
Thank you. Thank you.